Good morning. It is my pleasure to introduce Dr. Elaine Jaffe, one of the most influential hematopathologists of our time. Dr. Jaffe is an NIH Distinguished Investigator in the Laboratory of Pathology at the National Cancer Institute, where her career has spanned nearly 5 decades and profoundly shaped how we define, classify, and understand lymphoid neoplasms. Dr. Jaffe received her undergraduate training at Cornell University and earned her MD from the University of Pennsylvania. After anatomic pathology training at Georgetown and an NCI residency in hematopathology fellowship, she joined the NCI as a senior investigator in 1974 and has continued there as a leader in diagnostic and investigative hematopathology ever since. Her work has bridged rigorous morphologic examination and modern immunologic, genetic, and microenvironmental approaches to cancer, elucidating foundational mechanisms of lymphomagenesis. Scientifically, Dr. Jaffe is best known for transforming lymphoma into biologically meaningful entities. Her contributions were central to the development of modern classification systems, including the Real and later WHO classifications, that link morphologic recognition to immunophenotype, genetics, and clinical behavior, a framework that underpins disease-specific diagnosis and therapy today. Her laboratory studies on the cellular origins of lymphomas, the distinction between B and T cell neoplasms, and the role of the tumor microenvironment have directly influenced both pathology practice and clinical oncology. Dr. Jaffe's scholarship, leadership, and mentorship have been recognized with many of the field's highest honors: election to the Institute of Medicine through the National Academies, the F.K. Mustafi Distinguished Service Award through USCAP, the Henry Stratton Medal Award through ASH, the Rue Whipple Award through the ASIP, the AACR James Ewing Thelma Dunn Award for Outstanding Achievement in Pathology and Cancer Research, and numerous other NIH and Department of Health and Human Services career awards. In 2019, she was named as an NCI Distinguished Investigator. Dr. Jaffe is also widely admired as a teacher and mentor, a pathologist who expects meticulous morphology, but also encourages trainees to ask the next biological question and to collaborate across disciplines. Her editorial and society leadership, including presidencies and editorial board service, help institutionalize the standards that allow pathologists and clinicians worldwide to speak the same diagnostic language. Please join me in welcoming Dr. Elaine Jaffe. Thank you, Dr. Jaffe, for joining us.
Well, thank you for that very gracious introduction, and I hope to persuade you that the microscope is still a tool that we can continue to use for disease discovery. I'd like to first acknowledge the passing of Dr. Deborah Powell, uh, Debbie, as I knew her. She was a resident in the class of 1968 at NIH. Here she is in our autopsy room with her fellow residents. I started my residency in 1970, just after she left, and went back to Georgetown. I was uh, pleased to follow her remarkable career as a pathology chairman, dean, and leader in medical education. And she was a wonderful role model and example for all of us of how pathologists can have a major influence in medicine. Um, when I started my residency in 1970, there was the beginning of major changes to the classification of lymphomas. There were early techniques that could identify both T cells and B cells, so-called E-rosettes, surface immunoglobulin, and EAC rosettes. I've asked some of our residents if they knew what an E-rosette is, and most of them had no idea. So T cells bind sheep erythrocytes in the cold, and this is the antigen that we recognize as CD2 on T cells. Of course, we no longer use E-rosettes to identify it. So at this time, there was a great interest in modernizing the classification of lymphoma. 6 different classifications were proposed, and meetings were held in Airlie, Virginia, and in Italy. And here you can see some of the leaders in the field at that time: Luke, Sperard, Rappaport, Dorfman, Leonard, and James Butler. Um, the meetings were not successful in reaching consensus, so the NCI decided to do a study to test all the individual classification systems. And six schemes were tested on about 1,200 cases using both six expert pathologists and control pathologists. The pathologists looking at the cases had only H&E stained slides. Immunostains didn't exist at that time. The diagnoses were first made without any clinical data, and later they got to re-review the slides, knowing only age, sex, and anatomic site. Kaplan-Meier's survival curves were generated, and not surprisingly, no system was superior to any other. Following this study, the NCI proposed the so-called working formulation for clinical language. This was supposed to be a common language that you could use regardless of the classification system in your favor. But it was largely the Rappaport system with minor changes in terminology. It really didn't define disease entities. Many of the categories were heterogeneous, such as diffuse mixed lymphoma, which was likely a mixture of both B and T cell neoplasms. It relied only on H&E, and while it was widely used in the US, it was resisted in Europe and Asia, where the Kiel system was popular. But meanwhile, really rapid progress was being made regarding the characterization of lymphoid neoplasms. So in 1974, David Mason and Clive Taylor first used immunohistochemistry on routine paraffin sections. Then became the revolution from Kohler and Milstein and the development of monoclonal antibodies. And in 1982, David Mason again used monoclonals for the first time by immunohistochemistry in paraffin. We discovered immunoglobulin gene rearrangement as a marker of lineage and clonality, and the discovery of oncogenes linked to specific subtypes of lymphoma, c-Myc for Burkitt lymphoma, and of course BCL2 for follicular lymphoma. So about this time, Peter Isaacson, in conjunction with Harold Stein, decided that it may be a opportune time to bring together some of the, at that time, younger pathologists to discuss issues in classification. And he invited about 24 of us to come to London to discuss three major topics. One was malt lymphoma. He had proposed the concept of malt lymphoma for mainly lesions involving the gastrointestinal tract, but other mucosal associated sites. And this had been rejected by Carl Leonard. There were two subtypes of lymphoma that had a lot of overlapping features: intermediate lymphocytic lymphoma in the modified Rappaport system and centrocytic lymphoma in the Kiel system. And finally, we were beginning to see a close interrelationship between Hodgkin's disease and non-Hodgkin's lymphoma. And perhaps not surprisingly, consensus emerged on a number of issues, and many of the pathologists were talking the same language. And here you could see some of the participants at that time: Stefano Polari, Harold Stein, Nancy Harris, John Chan from Hong Kong, George Del Sol from France, Roger Warnke, that's me, Tom Grogan, and Mike Cleary. One of the first topics that was discussed among the group was the nature of so-called centrocytic lymphoma and intermediate lymphocytic lymphoma. Actually, earlier in 1991, Mark Raffeld and I had published an editorial in Blood proposing the term mantle cell derived lymphoma. It was becoming clear based on genetic studies and the presence of the BCL1 translocation that intermediate and centrocytic lymphoma were the same entity. In 1992, the ILSG codified the emerging consensus on mantle cell lymphoma, facilitated by the translocation. A second publication from the ILSG recommended a formal distinction between nodular lymphocyte predominant Hodgkin's and classic Hodgkin's lymphoma. I think we're still grappling with that um, distinction. And the ICC went so far as to remove the name Hodgkin's from nodular LP to emphasize its distinctive nature. So by the third meeting, the pathologists attending the ILSG concluded that the most practical approach to lymphoma categorization at this time was simply to define the diseases that we think we could recognize using currently available morphologic, immunologic, and genetic techniques. And the real classification was published in Blood, and listed the entities that were accepted. It really represented a new paradigm in the classification of lymphoid neoplasms because it recommended that individual diseases could be defined based on a constellation of clinical and laboratory features. Morphology is a starting point, but one needs to consider immunophenotype, genetic features, clinical presentation, and course. And it was appreciated that the site of involvement was often a signpost for underlying biological distinctions, as had been recognized by Peter Isaacson for malt lymphoma. And of course, we see this today for many other entities as well. It was based on the building of consensus through input from 19 expert hematopathologists. So it was not a theoretical scheme, but later based on published data, and accepted as a basis for the WHO classification. So in March of 1994, actually before the publication appeared in Blood, a group of the pathologists involved were invited by Vince DeVita, then NCI director, to meet with representatives from the clinical oncology community. And the response from the clinicians was very mixed and surprisingly hostile, at least to us. I think they were angry that we had the temerity to propose a classification without involving them, and perhaps that was a mistake at the time. So at the time the classification appeared in Blood, in the same issue was an editorial from Saul Rosenberg. And here are just a couple of quotes from that editorial. He said, despite the hope of many, separation of lymphoid tumors into B or T cell origin as major subtypes is not helpful to the clinician. Hopefully, not too many clinicians in the audience would agree with that concept today. He was also upset that the classification did not clearly define prognostic groups. One thing that the oncologist liked about the working formulation was that you had low grade, intermediate, and high grade. And so that was very easy to set up clinical trials. So identifying individual disease entities was a step backwards in his view. And finally, he stated that with the tools and methods to precisely dissect each patient's cell of origin, every patient's lymphoma might be different, and it's doubtful that such complete knowledge would be helpful. Well, again, I think not too many people would agree with that today. Today, we're using NGS for developing targeted therapies, and every tumor is different. His last point was that if a classification is going to be used by the average pathologist, it has to be reproducible and easily learned. And this led Jim Armitage at the time to do another study to test the efficacy of the ILSG classification. And using 1,400 cases, five expert but unaligned pathologists who were not part of the ILSG visited each site and classified the various cases. 20% of the cases were randomly re-reviewed to test reproducibility, and diagnostic accuracy and reproducibility was at least 50%. So again, the last condition proposed by Rosenberg had been satisfied, and this was easily learned and readily applied. So, what are the advantages of a disease-oriented approach to classification? Well, we recognize that it's required for the development of new therapies. Here are three small B cell neoplasms: hairy cell leukemia, malt lymphoma, and mantle cell lymphoma. Clearly, very different clinical pathologic entities treated in different ways. And of course, this is also required for the investigation into the pathogenesis of specific entities. It's important to define an entity as best you can before you determine its molecular pathogenesis. And this technique is still widely used as we move forward to identify newer entities. So the next steps led from the real classification to the WHO. In 1993 and 1994, Les Sobin, who was then working in IARC in Lyon, invited the Society for Hematopathology to coordinate the next WHO classification. And the Society for Hematopathology decided to join forces with the EHP in this effort. This is the first edition of the WHO classification. It was published in 1976. I don't know how many of you have familiar with the old blue books that used to sit on our library shelves. And these were simply just photographic atlases showing H&E pictures of the various entities with mostly brief figure legends. There never was a second WHO classification. And in 1994, Paul Kleihuis became the IARC director, and he really transformed the Blue Books into their current format, recognizing the importance of integrating pathology with genetics and clinical findings. This led to the third edition of the WHO classification, which employed the concepts of the real system. However, before publishing the WHO, we recognized that it was very critical to involve the clinicians in this process. And so the first WHO Clinical Advisory Committee meeting was organized in 1997. It was organized by the two societies with the participation of more than 200 individuals from 24 countries. And the meeting was organized around a series of questions. The pathologists presented the proposed classification. The clinicians presented data relevant to each question. Discussion was held to arrive at consensus on each issue, with voting held if necessary. And there were post-meeting polls and additional meetings to resolve issues. Prior to the WHO Blue Book, there were meeting reports that were published in both clinical and laboratory pathology journals to inform the general public about what was coming down the pike. So here are the participants at the first WHO meeting in Airlie, Virginia. And as you can see, peace and tranquility prevailed in the Virginia countryside, and consensus was easily reached. Why was the Airlie Conference in 1997 a success, while in 1975 it failed? Well, in 1975, the classifications were the work of individual experts who were brought to Airlie under duress. Uh, Clearly, a knowledge of the immune system was at its infancy at that time. Routine immunophenotyping was not available. Molecular oncology was uncovered, undiscovered, and the proposals could not be tested empirically. In 1997, the situation was very different with the classification, the collective work of multiple experts, and pathologists and clinicians worked side by side to formulate the classification. This model has been used successfully with successive WHO classifications, the fourth edition in 2008, and the revised fourth edition in 2017. What happened in 2022? Well, in 2022, IARC, representing the WHO, decided to publish a fifth edition classification, but they rejected the collaboration with the EHP and Society for Hematopathology and the process of the Clinical Advisory Committee as had been employed earlier. And Ian Cree stated that the process was an anomaly. The executive committees of the two societies voted to proceed with a planned clinical advisory committee meeting without the endorsement of IARC. And I think many leaders in hematology and oncology supported this decision. A clinical advisory committee meeting was organized in Chicago with 149 international participants. There were parallel meetings for both the lymphomas and the myeloid diseases, and a number of pathology chairs and clinical chairs are shown here. And the results were published in Blood in 2022 in a series of manuscripts. The first of these manuscripts dealt mainly with the mature lymphoid neoplasms, lymphomas, and mature leukemias, representing again about 75 pathologists and clinicians from around the world. So, where are we now? Um, well, um, uh, Today I'd like to present the major changes reduced in the ICC classification since the last WHO fourth edition of 2017, discuss some of the key differences with the WHO fifth edition, review some of the differences in rationale and conceptual approach used by the two systems, and hopefully review opportunities for resolution going forward. First, we'll discuss what's new in B cell neoplasms, discussing follicular lymphoma, diffuse large B cell lymphoma, and high grade B cell neoplasms. This is the view of follicular lymphoma from the perspective of the ICC. A major dividing point is between what we consider conventional or classic follicular lymphoma associated with the BCL2 translocation and alternative forms of follicular lymphoma that lack the BCL2 translocation. Within conventional follicular lymphoma, of course, there are the incipient lesions, FL-like B cells that we discover in the peripheral blood, in situ follicular neoplasia, and duodenal type follicular lymphoma, as well as various forms of transformed follicular lymphoma, the most common being diffuse large B cell lymphoma. But now we recognize that even Hodgkin's lymphoma and histiocytic sarcoma can arise as a transformation of underlying follicular lymphoma retaining the BCL2 translocation. The ICC decided to retain the grading of follicular lymphoma as grade 1 to 2, grade 3A, and grade 3B. In contrast, the WHO recommended grading as optional. But I think it's important to bear in mind that the grading of follicular lymphoma is still a challenge, and ancillary studies are really key for the distinction of grade 3A and grade 3B. And without using ancillary studies, I think this distinction is often not reproducible. I think that's case in my consultation practice. I get cases sent to me as 3B that I would classify as 3A and vice versa. A follicular lymphoma grade 3 is largely associated with the BCL2 translocation. Most of these patients have advanced stage, frequent bone marrow involvement, and are largely negative for MUM1 or IRF4, whereas follicular lymphoma grade 3B is often associated with diffuse large B cell lymphoma. BCL2 translocation is uncommon, and many cases are positive for MUM1. Another category that's been studied in recent years is the heterogeneity of BCL2 negative follicular lymphoma. And it's become clear that this is really heterogeneous. There was one category that was highlighted by the ICC as representing a potentially new entity, described as a provisional entity in the ICC. And this has a rather cumbersome name, BCL2 rearrangement negative, CD23 positive, follicle center lymphoma. These cases were first described by Katzenberger in Germany. They often are localized stage 1. The inguinal region is probably the most common site of presentation, but they can occur in other regions. They often have diffuse areas, and I think were first recognized because they were largely diffuse. But now we're starting to recognize more cases of this entity that have a follicular growth pattern. A key feature of this entity is that STAT6 mutations are very common. CREB-P mutations are also present, but are not specific and are seen in other follicular lymphomas. This disease was first recognized by the presence of 1p36 deletion in a subset, but in subsequent studies, this is not seen in a very high frequency of cases, probably less than 30%. So most of these patients have low stage disease, a very good prognosis, and are really managed very differently than conventional follicular lymphoma. Here's an example of a case that we saw, and as you can see, this case does have, let's see, I've got to put on my pointer. Okay. So this case, as you can see, does have a follicular growth pattern. The neoplastic cells are seen both within follicles as well as with an interfollicular distribution. And CD23 is highly expressed both in the cells within the follicles as well as the interfollicular component. BCL2 protein can be weakly positive, but BCL2 translocation is absent. Another, I think, major category that was recognized by the ICC are the category of follicular lymphomas seen in young patients, mainly under the age of 30. Probably the first of these to be recognized is a pediatric type follicular lymphoma. This usually presents as stage 1 disease in cervical lymph nodes. Recently, we reported cases that arise in the conjunctiva, and have identical genetic changes. This is a condition that's much more common in males than females, at least a 10 to 1 male to female ratio. And many of these cases show marginal zone differentiation. So they may be, you may consider a differential of marginal zone lymphoma, but cases with marginal zone differentiation have the genetic pattern of the parent disease and are considered part of the same entity. Another form of follicular lymphoma in young patients is testicular follicular lymphoma seen in young boys. This has an excellent prognosis, and following orchiectomy, these patients really do not require further therapy. And finally, we have IRF4 large B cell lymphoma. This is most common in the tonsil and Waldeyer's ring, seen equally in males and females, can be follicular or diffuse. Often there's a focal follicular growth pattern. And of course, a key feature is co-expression of MUM1 secondary to IRF4 rearrangement, where, as well as BCL6 and CD10 expression. So this just summarizes the genetic features of these entities, which identify them as separate diseases. MAP2K1 is the most common mutation in pediatric type follicular lymphoma. It's absent in testicular follicular lymphoma, which shares a mutational profile that resembles other extranodal follicular lymphomas, interestingly. And finally, IRF4 large B cell lymphoma is characterized by breaks and mutations in the IRF4 gene. So the nature of IRF4 rearranged large B cell lymphoma has been somewhat controversial. The ICC took the step to link it to other forms of follicular lymphoma because these cases generally have a relatively good prognosis. Clearly, they often have a follicular growth pattern. The WHO considered it a variant of diffuse large B cell lymphoma. And so this is one of the things that needs to be resolved in the future. This is one of the clinical studies published in recent literature and shows that large B cell lymphoma with IRF4 rearrangement has an excellent prognosis, and they questioned whether these patients really need to be treated like diffuse large B cell lymphoma, and they can be managed with more conservative therapy. So I'm just going to run through the differences between the ICC and the WHO for follicular lymphoma, because I think this is one of the categories where major differences have occurred. So, as I've already said, the WHO does not recommend grading, although grading is considered optional. The WHO has a category of follicular lymphoma with predominantly diffuse growth pattern. It's most likely equivalent to, just going to go back to my pointer here. It's most likely equivalent to BCL2 negative CD23 positive follicular lymphoma, but is less precisely defined. Both groups recognize pediatric type follicular. The WHO does not list testicular follicular lymphoma as a separate entity, and it's actually included within classic follicular lymphoma, although clearly biologically it's very different. I've already discussed the differences in large B cell lymphoma with IRF4 rearrangement. The WHO recommended the term follicular large B cell lymphoma rather than grade 3B to emphasize that it's really more closely related to diffuse large B cell lymphoma than to other forms of follicular lymphoma. I don't think this is unreasonable, and this may be adopted in future classifications. The term follicular centroblastic lymphoma actually is being discussed as an alternative. The WHO has a category of follicular lymphoma with unusual or uncommon cytologic features. I'm not sure exactly what this is. There are cases that were described in a study from France by Camille Laurent of grade 3 follicular lymphoma that are not 3A and not 3B. And a lot of those have funny cytologic features. They can be blastoid. And I think that's probably what most of these are. And both groups recognize primary cutaneous. So, to sum up, the ICC tried to define the diseases by clinical, pathologic, and genomic features, including BCL2 arrangement and or other alterations. Whereas in the WHO, the other variants beyond classic follicular lymphoma are largely defined histologically and not on biological parameters. There are some other differences in the classification of small B cell lymphomas between the ICC and the WHO fifth. The WHO fifth eliminated the category of B cell prolymphocytic leukemia and hairy cell variant and merged both of these under the term splenic B cell lymphoma leukemia with prominent nucleoli. I think this was criticized by many of the clinicians who objected to both the elimination of B cell prolymphocytic leukemia and the elimination of hairy cell leukemia variant. Perhaps hairy cell leukemia variant is not the best term, but I think these cases are well identified. They have certain recurrent genomic changes, and actually, we have a large program in hairy cell leukemia here at the NIH, and also recognize hairy cell leukemia as a distinctive entity. So, turning to the more aggressive lymphomas, I think both classifications have de-emphasized morphologic and phenotypic variants. I never liked the term double expressor because I think it's a hodgepodge of biologic entities. And CD5 positive diffuse large B cell lymphomas do have some common features. There's been great deal of discussion as to whether we should move forward with a molecular classification of diffuse large B cell lymphoma. Has been defined by several groups, the Lustout and the LLMPP, as well as Margaret Shipp and their classification. And clearly, there are biological entities that are identified by this approach. But this is probably not yet ready for prime time usage as a routine diagnostic tool. However, clearly the field is, I think, moving in this direction. Another topic of discussion was, is it time to recognize extranodal diffuse large B cell lymphoma as a separate entity? It's clear that many extranodal large B cell lymphomas share biological features. These are represented by the MCD category of the LLMPP and C5 of the Shipp classification. Types are primary CNS and testicular diffuse large B cell lymphoma. Also includes, interestingly, intravascular large B-cell lymphoma. However, other extranodal diffuse large B-cell lymphomas in breast, adrenal, thyroid are much more heterogeneous and don't clearly fall into this group. So the ICC accepted primary diffuse large B-cell lymphoma as a specific entity, as suggested by the WHO, closely related to certainly primary CNS disease, and feels that further studies are necessary to determine the nature of other extranodal large B-cell neoplasms. Another fairly controversial topic has been high-grade B-cell lymphomas. I think it's very clear that there's very poor reproducibility in what pathologists call high-grade B-cell lymphoma based on H&E and routine immunohistochemistry. In a study actually recently published in Blood Advances, um, even by experts, cytologic recognition as high grade was very poorly reproducible. So, of all of the cases contributed to the study by members of the LLMPP, all of whom are expert hematopathologists, when they were reviewed by the full panel, only 42 were accepted as high grade B cell lymphoma upon panel review. So if the experts can't make this diagnosis in more than 50% of cases, I think it's kind of hopeless to expect the average pathologist to make this diagnosis accurately. However, I think it is important to recognize certain high-grade lesions with distinctive biological features. So the main two categories are high-grade B-cell lymphoma with MYC and BCL2 rearrangement. These, by gene expression profiling, have a dark zone signature. And the category of high-grade B-cell lymphoma with MYC and BCL2 rearrangement is much more controversial. The clinical implications are less certain, and it's heterogeneous in terms of NGS. This is the ICC proposal for high-grade B-cell lymphomas from the ICC. So it recommends the recognition of high-grade B-cell lymphoma with MYC and BCL2 rearrangement. It's appreciated that this has a broad cytologic spectrum. Some might look more like a large cell, some may look more Burkitt-like, but it's considered a single entity in the ICC. The WHO recommended that you classify them further as either large cell or high grade based on cytologic features. And as I've already said, I think this distinction is poorly reproducible. The ICC retained high-grade B-cell lymphoma with MYC and BCL6 as a provisional entity, recognizing that it may not be a homogeneous disease. The WHO decided to eliminate it, and these cases are included in either diffuse large B-cell lymphoma or high-grade NOS based on their cytologic features. And finally, there's the category of high-grade B-cell lymphoma NOS. This is, I think, a diagnosis that should be made very rarely. I actually use it very sparingly. I may make this diagnosis about once a year. So I think it's a category that I hope will go away in the future. But so another entity that's been was recognized in the WHO fourth edition was what was called Burkitt-like lymphoma with 11q aberration. These are mainly seen in children, and they can look a lot like Burkitt lymphoma, but they mainly present with nodal disease, not extranodal disease. The ICC renamed this large B cell lymphoma with 11q aberration, whereas the WHO put it in the high-grade category, calling it high-grade B-cell lymphoma with 11Q. I think this disease does not have high-grade clinical features. It has a favorable prognosis with adequate treatment. These patients are not at risk for CNS disease. They don't need CNS prophylaxis. So the ICC felt that calling it high grade led to over treatment for this disease entity. Further studies have shown that also it has a mutational profile that's closer to diffuse large B cell lymphoma and lacks the genomic hallmarks of Burkitt-like lymphoma. So clearly it's not Burkitt-like by that criterion. So this is sort of a flow chart that you can use for the diagnosis of aggressive B-cell lymphomas today. First, you need to recognize a number of specific entities, most of which we didn't have time to discuss, but PMBL, EBV positive diffuse large B-cell lymphoma. If you're left with a diagnosis of diffuse large B-cell lymphoma NOS, you want to do FISH to try and recognize the double hit cases. Both classifications recognize that you at least use the Hans system to identify cell of origin. And I think mutational profiling is certainly on the horizon for future clinical practice. I'm just going to take a couple of minutes to discuss some of the T cell lymphomas. There are relatively few changes in the ICC from the prior classification of T cell lymphomas. Shown here in bold are some of the diseases that have undergone a revision, mainly in terms of nomenclature. Everybody recognizes follicular helper T cell lymphoma as the most common type of T cell lymphoma with a mutational profile that's highly recurrent. IDH2 and RhoA are the most specific for AITL, but TET2 mutations and DMT3A are also found in B cells and myeloid precursors in affected patients with this disease. So, angioimmunoblastic T cell lymphoma is really characterized by a proliferation and sometimes clonal expansion of B cells, as well as neoplastic T cells. Recent data indicates that the B cells and myeloid cells share some of the mutations with the neoplastic T cells. And it's now the thinking is now that AITL likely arises in hematopoietic stem cell with subsequent clonal evolution leading to the ultimate disease entity. Another controversial issue is, can we better classify peripheral T cell lymphoma NOS? Various approaches have been used, such as using gene expression profiling. This is not yet recommended for routine clinical practice, but remains a topic for further investigation. Anaplastic large cell lymphoma is clearly a broad category of T cell lymphoma. The ALK negative cases are clinically and genetically heterogeneous. And in the ICC, it was recommended that cases with DUS22 rearrangement be recognized as a specific subtype, as they have a better prognosis. These are recent data just published by Andy Feldman in Blood at the end of 2025, again showing the excellent prognosis for those cases with DUS22 rearrangement. He also subdivides the ALK negative cases and to phosphostat 3 positive and negative. There are some distinctions here, but they're not, I would say, critical. It's also been appreciated that the DUS22 mutated ALCL has a distinctive morphology and a phenotype in that it's LEF1 positive and negative for cytotoxic markers, in contrast to most other forms of ALCL. I think, in the interest of time, I'm going to uh, uh, skip through most of the GI cases. But one difference in the ICC is that the IC proposed that we recognize type 2 refractory celiac disease as a clear precursor of EATL, since most of these patients will progress to EATL within 5 years. There are other indolent T and K cell proliferations, which have been recognized by both groups, indolent clonal T, LPD, and indolent NK cell, LPD, in both classifications. A new entity, again recognized in both classifications, is a category of primary nodal EBV positive T and K cell lymphoma. T is more common than NK. These may not be suspected on H&E because they often don't show necrosis. They're seen in increased incidence in elderly patients and patients with immune deficiency. So we've clearly seen an evolution in the classification of lymphoma from the era of individual entities such as reticulum cell sarcoma and lymphosarcoma. The introduction of modern techniques has certainly led to a better understanding of hematolymphoid neoplasms. Today, we're still grappling with both the ICC and WHO. And I think consensus hopefully may lie ahead. The WHO participants have agreed to have a clinic classification advancement meeting. They didn't want to use the term CAC, so we have a new term. It's a CAM. There's an organizing committee made up of representatives from both the ICC and the WHO. The CAM will bring together international experts to address this controversy. And the goal is to provide a basis for international consensus and the future WHO 6th edition, which we hope can be achieved in the next few years. So I thank you for your attention, and I'm glad to accept any questions.
Thank you, Dr. Jaffe. I do have a question for you. What advice might you have for either current trainees in hematopathology or faculty new in practice? What do you think is the best way to get started of putting together a career in research in translational hematopathology?
Boy, that's well, I think if you come across a case and you don't know what it is, don't discard it. I used to have a goodie file. It was a little 3 by 5 cards in a little black box. I still have it. And if I saw a case and I couldn't figure out what it was, I would make some notes about it and put it in my goodie file. If I saw another one, I would add it to the goodie file. And frankly, a lot of the entities that have been recognized in recent years have been recognized by that method. We first reported histiocytic sarcoma arising in patients with follicular lymphoma. And I accumulated those cases over a period of about 10 years. And finally, we did fish or PCR on the histiocytic sarcomas and discovered that they had the BCL2 translocation. They had the same immunoglobulin gene rearrangement as the earlier follicular lymphoma, and led to a series of about 8 cases, which was published in Blood, and now we accept that as an entity. So I think that story has been probably repeated for most of a lot of the papers that are in my CV. That was true for pediatric type follicular lymphoma. It was true for IR4 large B cell lymphoma. We began to see these funny cases and uh, actually sent them first to Reiner Sieber to first reported the IR4 rearrangement. So I guess um, that would be my word of advice.
Are there other questions from the audience for Dr. Jaffe? Uh, Dr.
Uh,
Albasians.
I have a question. I'm not sure if somebody else is
I
talking
think,
also.
oh, I think Dr. Elbaz had his hand up. So if
Oh,
you,
for sure. Go
yeah,
ahead.
Thank you for that wonderful presentation. I just wanted to know, like, in your experience of the left one and the ALK negative ALCL, the DOS 22, how, like, positive is it kind of like with the same expression pattern you would see in a CLL or some of the Burkitt lymphomas that are positive, or it has a different, uh, like, expression like pattern in the IFC for the left one?
Um, there's nothing distinctive about the left one. It's just the fact that it's positive in the tumor cells, whereas other forms of ALCL, ALK positive and ALK negative, are typically negative. So in those cases, you'll see it in background reactive T cells, but not in the tumor. But I think it's important to couple that with the cytotoxic markers. The cytotoxic markers are probably a little bit even more important in that distinction. So if you have a case of ALCL that's negative for, I prefer granzyme B over TIA. But I think granzyme B is a little bit more sensitive in making that distinction. I find TIA a little bit harder to interpret because the granules are often small and it's less consistent.
Okay, thank you.
Dr. Beckman?
Thank you. Thanks. First of all, thank you for that great talk, Dr. Jaffe. I wish we had the whole day to sit and listen to your ideas about things. I particularly enjoyed the information you presented on follicular lymphoma, um, because I'm just every day, every week, astounded at how complicated follicular lymphoma is. So I wanted to ask you two questions. First, about CD23 expression and whether you've noticed any interesting patterns in terms of follicular lymphomas that express CD23 and then to progress into diffuse large B cell lymphoma. Is CD23 ever useful or interesting in that setting? And then my second question is the idea of this follicular lymphoma that might have both BCL2 rearrangements and a MYC rearrangement. Do you make that diagnosis of a follicular lymphoma with a MYC rearrangement, and when would you consider it?
Okay, to answer the first question about CD23, I haven't appreciated anything unique about CD23 in terms of risk of progression to diffuse large B cell lymphoma. For the entity with the STAT6 mutation, the CD23 should be both in the follicular as well as interfollicular compartment. I think if it's just in the follicles, that's less reliable in terms of recognizing those cases. And we do our actually STAT6 is not on our NGS panel, but we actually can pick up the STAT6 mutation using RNA-seq. So we sometimes try to confirm it by that method. The second question was, there was another question. What was
about MIC rearrangements
oh, MIC.
in follicular
So
lymphoma.
we don't recommend that you do FISH for MIC in ordinary follicular lymphoma. There are a number of papers that have looked at cases of what you would call follicular lymphoma, grade 1 to 2, or even grade 3A with MIC and BCL2, and it's not clearly of ominous prognostic significance. So those patients don't have a major adverse prognosis based on the MIC rearrangement. So I think we don't fully understand its impact in predicting progression to a real high-grade B-cell lymphoma. It doesn't always predict progression. I think those patients clearly should be followed closely, but I don't think they deserve different therapy up front, at least by our clinicians.
Thank you.
Well, thank you. I think we're at 9 o'clock. So thank you, Dr. Jaffe. I really appreciate the generosity of your time to share this knowledge with us.
Okay, I think this is third time is a charm. We've scheduled this at least 3 times through government shutdowns and everything else. So, okay.
All right. Thank you so
Thank
much.
you. All right.